My name is Mel Vincent. I'm a psychiatrist and I've been working at Edgewood since 2002. I kind of stumbled into addiction as a psychiatrist because there aren't many addiction psychiatrists, and I was on call for a hospital that had an addiction service. And like many doctors and psychiatrists, I realized that I had not had any significant training in addiction in the years that I'd been in school. And so around 1992, I completed my addiction medicine certification and was going to work on an inpatient unit for 3 months in addiction. My 3 months turned into 3 years, and I developed a passion for addiction, which I've had ever since. Working at Edgewood, I've been well aware of trends and changes that are happening in the addiction field over the last several years. Obviously, the most profound change that has affected addictions in British Columbia and certainly North America and beyond has been the so-called fentanyl epidemic or opioid epidemic. So I wanted to take a little bit of time to go into that in a bit more detail, put the historical context in terms of the family of drugs and addiction to opioids, and then look at how that's kind of taken us to where we are currently with some of the challenges and how we can save lives and treat people in the best possible way. So if you go back into history, what you find is that opium has been a commodity that has been highly valued going back for thousands of years and has a very long history. Opium happens to contain two different opioids which are well known, and those opiates are morphine and codeine. Most people will recognize those names because they're still being used. Tylenol number 3 and Tylenol number 2 contain codeine. So these are compounds that have been around for a long time, synthetically manufactured, but have been in the original opium form for thousands of years and valued both for their management of pain historically, which was discovered very early on, in addition to their euphoric and mood-altering propensities. So as time went on, obviously, opium was a very valued product, and it had been for many years. One of the major changes that we'll be talking about is how opium and how the family of drugs, opiates, has changed and evolved over time as we become more sophisticated with managing and making chemicals. And so really opium remained as an exclusive drug for a long time until the 1500s when laudanum came about. And laudanum was a way that they had discovered to purify morphine so that it was more potent and stronger. And it remained a medication that was valued and abused and used for a long time. Opium itself became so addictive in China that at one point the emperor decided to ban the importation of opium from the Brits, and very shortly thereafter received threats, and the decision was changed, and they allowed the continuation of importation of opium into China. And so you had the opium dens, and addiction to opium was a very long-standing phenomena. The next change really occurred in the 1800s when they were able to actually purify morphine, and so morphine became a compound in its pure form. And therefore it was much more potent, and people could become addicted to morphine, which became a very popular addiction towards the 1800s. Around the late 1800s as well, they discovered another compound called diacetylmorphine, more commonly known as heroin. And heroin was presented at that time as a way to treat morphine addicts because it was non-addictive. However, as we all know, heroin in fact became very addictive, and so the turn of the century you had people that were addicted to morphine also addicted to heroin. So at that point, we had another epidemic of opium, which, essentially at that time was housewives who were encouraged to use marketed morphine, which was available in various commercial products to help them to relax and to calm, and in fact was even promoted to be given to their children so that they could have nice, peaceful evenings. The other historical context is that alcohol was not to be drank by women, and bars were pretty much exclusively accessible to men, and therefore women turned to morphine and the opioids at that point in time. So if I fast track from that historical sort of background into when I started my career, which was in the late 1980s, early 1990s, what we looked at that time was primarily two different ways that people became addicted to opioids. One was through management of pain conditions, and the second was through very extensive addiction careers where people had gone through various drugs and compounds that they were addicted to, including at that time alcohol and speed and cocaine, and eventually ended up with intravenous addiction primarily to heroin. So when we looked at what heroin addicts looked like back in the early 1980s, 1990s, these were generally people who had gone through a long trajectory of addiction to various compounds. They often had criminal histories, and they were almost looked down on by other addicts as being the worst of the worst. And so, a lot of the studies in methadone and where harm reduction really had some of its early manifestations was around managing intravenous drug use, trying to get methadone as a replacement for heroin, looking at needle exchanges, trying to reduce the risk of infectious disease, etc. So at that time, the sort of the poster child, if you will, for opiate addiction was, if it wasn't from someone on pain medications for a pain condition, it was the heroin addicts that had gone through very severe addiction. And so, really that's where we looked at treating addiction for opioids, in the residential settings that I was working in. If we then fast track and we look at, well, what do opiate addicts look like currently? What we find is if you were to walk through the doors of Edgewood and take a meander around and look at the patients that are there, unlike the previous ones that had more of a hardcore criminal background, mostly in their 40s and 50s with a few decades of progression, we see a much younger crowd, more in the 20s and 30s, although obviously they can be into the 40s and 50s as well. Instead of starting with heroin, most of them are getting started with prescription opioids, and so we see people that get started with OxyContin or Dilaudid or prescription medications that are around. And that's more of a starting point than starting off with heroin, which was more the case before. And so, if you look at historically, you can see that we've gone from opium into laudanum, into pure morphine, into pure heroin. And now the history has gone into more and more both naturally occurring or what they call semi-synthetic opiates, which is where you take the original morphine and codeine and you do a little tweak of the molecule and you make something called a semi-synthetic opiate, all of which have action at the opiate receptor, which is where opiates do their thing in our brain. And then we end up with synthetic compounds. So we have this whole diverse range of options of opioids, from the pure original opiate, morphine, codeine, to semi-synthetic to totally synthetic drugs. And that's where we get into where we're at now. So the biggest change in the field in the last, I would say the last decade or less, has been the introduction of fentanyl. And so fentanyl is many-fold more potent than any of the drugs we've had around before. And so where before in treatment settings, you used to really have two different sort of options around treatment. One was a total abstaining from any addictive compound, including opiates. So you would have gone into a treatment center or a detox, you would have been taken off your opiate, you would have then been expected to abstain totally from that class of drug, or you were in a harm reduction sort of setting and you would have gone on to methadone, and those were your two choices at the time. If you now look fast tracking, you can see that almost all of the best practice guidelines now, because of the lethality associated with fentanyl and the high risk of overdosing, has now moved over to harm reduction strategies, primarily using either methadone, a newer medication called Suboxone, or looking at what are called opioid antagonists, which are medications you can take that block or put a no vacancy sign at the opiate receptor so that opiates aren't able to act there. And so naltrexone is available in various forms. So this has really changed the field of addiction dramatically. So where we have gone from abstinence or methadone, several years ago, one of the medical directors of Betty Ford and Hazleton, which have been the gold standards and kind of the pioneers in residential addiction treatment, made the announcement that they were no longer going to look at exclusively abstinence, but they were going to be starting people on methadone and Suboxone, and that was going to be a new residential treatment. Well, that was absolute heresy in the day, and it was a shock to, the long history of abstinence-based residential programs. And they really sort of led with 3 different streams that you had as options. So one stream involved total abstinence if patients requested it. The second involved going on Suboxone, which we'll talk about. And the third was to go into abstinence but take naltrexone on a daily basis so that you were blocking the opiate receptor, and if you did relapse, it wouldn't have the same action. And so that was really the way that it kind of worked. And there was 2 implications of that. I mean, one is we had this high-profile inpatient program switching to this harm reduction strategy. And then you also had the fact that recovery groups, which were still recommended, so Alcoholics Anonymous, Narcotics Anonymous, they had to adapt to this altered concept of what abstinence looked like. So in harm reduction, we looked at, well, if you were on methadone or you were on Suboxone, that was really considered to be abstinence because you're not using those drugs to get high and euphoric. You're using those to stabilize your opiate receptor. And that's how medically we looked at it, and that's how treatment centers looked at it. But if you were a member of Alcoholics Anonymous or NA, you're saying, well, what's going on? I mean, I abstained from my drug. I went through withdrawal and detox, and yet these people are coming in here on methadone and Suboxone, and they're still using opiates every day. They're not like me. And so there was this tension in the recovery community and people going in wanting to abstain from other classes of drugs, wanting to stay well and have the psychological, spiritual recovery that is offered through the 12-step programs, but they were being looked at differently. And so this really changed things. The other thing that really changed was around getting people off of fentanyl and onto methadone and Suboxone. So in the old days, if you will, when somebody came in on heroin, we could put them on Suboxone, and we would give them a 4 milligram dose. We could usually repeat that within 4 hours, and most people were settled and stabilized on 8 milligrams. Conversely, when people come in on fentanyl, we often end up using up to 20 milligrams of Suboxone on day 1 because their tolerance is so high, and in order to take away withdrawal, we need much higher doses. So that's really kind of changed the field. It's changed detox. The major criticism or argument about abstinence in the current environment is that if somebody comes into detox and they get withdrawn from their opiate of choice, and they leave treatment or they leave the detox and they relapse, they've lost that tolerance to the drug that they used to have before. So what happens physiologically is if I use any opiate drug and I have an addiction predisposition, I end up in a situation where I need more and more and more of the opiate drug to do the same thing, and that's called tolerance. And when people develop tolerance, they need more and more of the drug, and their body handles larger quantities of drugs without being in an overdose situation. If you go off of your drug of choice for even several days or a week or 2, your tolerance starts to go down very quickly, and if you go back and use what you used to use, or you come across fentanyl or its next relative, which is Carfentanil, which is 100 times more potent than fentanyl, you can easily overdose and die. And so that's been one of the major criticisms of abstinence, and is certainly why any best practice guideline now says detox is not treatment. Detox is the starting point to other kinds of treatments which are used. So hopefully at this point you have a sense of kind of where the field has come from, how we've evolved in terms of the compound itself and how opioids as a class have changed over time, how the potency has changed, how the clinical directions and best practices have changed, and maybe move from here to some of the challenges. So when I work on a day-to-day basis with patients, we find that there are different challenges we run into. One is that even though best practice guidelines are talking about the benefits of being on medication-assisted treatments, i.e. methadone and Suboxone, patients are not always very happy with being on those. And so it's very clear that some people go on methadone, Suboxone, they have a wonderful response, they get stabilized, their life improves, they develop life skills, and their life evolves in such a way that it's a very effective treatment. However, there are others who, even though they're on methadone and Suboxone, will continue to use illicit opiates. And the second thing is that even though people are on methadone and Suboxone, that really just is a treatment for opioid addiction. And so it doesn't really prevent anyone from using other classes of drugs that they can still get high from. So one of the challenges of working with patients that have been treated with methadone, while some of them have done very well, there's another group who don't like being on methadone, and so they come in with an expressed goal of stopping methadone or Suboxone. There are others that have been on methadone and Suboxone and have continued to use illicit opiates, so they're still injecting heroin, they're still using fentanyl, and still seeking that high in spite of being on methadone in high doses. Now, whether that's a failure of methadone or Suboxone, or whether it's a feature of the very high tolerance that happens with fentanyl, and people need such high doses of methadone or Suboxone to capture the opioid receptor and reduce the risk of relapse is an interesting question. A number of people don't like the side effects of being on methadone and so or Suboxone, and so for that reason they might want to go off of opiate agonist drugs. And the other is the inconvenience, if you will, of being on a medication, having to go to the pharmacy, especially in the early days, to have witnessed ingestion of the drugs that you're on. Eventually, for those that don't know, if you start on methadone or Suboxone, you initially have to have that supervised by a pharmacist. So you'd go to the pharmacy, you'd ask for your medication, they would witness you ingesting that compound, and then you would go on and carry on. Once you've demonstrated some stability, you're then given what they call carries. So, you can come in for witness dose one day, but then you get to take the next day or the next couple of days. And obviously, the longer you've been doing well, the more carries you get. And so people sometimes don't like that restricted lifestyle. If they want to take a holiday and be away for a few weeks somewhere on travel, they have to consider these options. And so some people just don't like the idea of being on a medication, and then there's some specific issues that they deal with. Some people say, I just want to be off of drugs. I just want to be at my brain, firing on all cylinders without the effect of drugs. One of the other challenges for these medications is how long does somebody actually need to be on it in order to be stable and then come off of it. They're now looking at a minimum of 1 or 2 years on these drugs. And so if you're looking at starting on a medication that you have to be on for a couple of years, sometimes that's a difficult thing to accept. And it's entirely feasible if you do well on it, you tolerate it well, you could be on it for decades or even for the rest of your life. And so that's a challenge for people. There are some difficulties getting off of it once you go on it. So people are often frightened of coming off of the drug, and what's withdrawal going to be like when I get tapered off of it? What's my risk of relapse going to be when I'm no longer on methadone or Suboxone? And so, these are some of the challenges that people come into. They also have a lot of ambivalence, and so sometimes people come in, they say, I want to be off everything. Next thing you know, they talk to some other people that are on these medications, and so they decide they want to go on it, and then they change their mind again, or vice versa. So there's a lot of clinical challenges. As mentioned, they still need to have addiction treated to other compounds outside the opiate family, because methadone and Suboxone, they block opiate receptors, but they do not affect people getting high from other classes of drugs. And so this remains an ongoing sort of challenge. So the kind of challenges we face now are, how do we prevent the fatalities that we're having? And really that becomes an issue of supply, and how can we provide people who are addicted and remain in their addiction, how can we give them a way of staying safe and not overdosing? And so methadone and Suboxone is one of those ways. The other is looking at things like safe injection sites or safe using sites. You may have been familiar with essentially vending machines that can distribute drugs to someone in very controlled circumstances. And so these are some of the new pioneering ways that people are looking at working with this. A whole other area that I think is also very fascinating around sort of opioid addiction and how we choose to treat it is the long history with treating health professionals. So for ages, if you've been a doctor or you've been a nurse or you've been a health professional that becomes addicted to opioids, which can be, pharmaceutical grade, or it can be heroin like anyone else, you would never have been put on methadone or Suboxone. So the gold standard treatment for health professionals has been that you would go into a treatment program like we have at Edgewood. You would do, like, say, a 2-month program as an inpatient. You would be detoxified from opiates. You would be abstinent for a period of time. You would then go into a post-residential treatment setting, often a safe housing kind of setting or an extended treatment program. And then at the end of that period of time, you would go back to your community and you would be on a so-called recovery contract. And so the expectation would be that you're going to continue to see an addiction counselor, you're going to go to a certain number of recovery meetings, you're going to get some kind of individual counseling or family counseling, you're going to have random drug testing done on a regular basis to confirm that you are remaining abstinent from your drug of choice. And what we know from physician recovery programs or health professional programs is that they actually have very good outcomes. And these are not because they're on methadone and Suboxone, but it's because they've had a very intensive addiction treatment. They've got a high level of motivation to remain abstinent for their career, and there's also a very high level of accountability. And so this has been another direction that has been popular, particularly for health professionals, but also for other professionals or for people in safety-sensitive work positions. So there are people that we see on a regular basis that come from industry that operate heavy equipment. They have jobs that are high-paying and valued, and they are very motivated to continue working with their company and work on their job. And so the question is there something unique about health professionals that they're able to benefit, or can we apply that same concept or principle to other people in other professions? If we give them the same intensity of treatment, will they have the same outcomes? And part of our idea is, yeah, they probably will. And so, giving them the same access to intensive, long-standing treatment with the same aftercare contracts seems to be helping people in these fields as well. And so that's been another sort of way to look at it. So I think it gives you some sense maybe of where we've come from in terms of opiate addiction, the kind of changes that have happened societally, the kind of risks that have been there, obviously the major public health concern around accidental overdoses from fentanyl, some of the strategies that have been used to try and address this and reduce morbidity and mortality. And this is going to be a moving target, and people are working together in terms of trying to help this community of individuals with addiction. I think we're seeing more of a marriage of harm reduction, caregivers and abstinent caregivers, and so now there's a more unified, more teamwork kind of approach to try and save lives, and I really like that direction. So thank you very much for bearing with me and listening to my presentation. I hope this has been of some interest and hopefully of some help to people, and all the best.